was going to say,
Medicare.
I have noon, and we will go ahead and get started with our August. And yes, it's August 2021, which is amazing in itself. But this is our August Swingbed Education webinar, and just wanted to provide some update to the waivers and just some clarifications. You know, they've been put in place, and then the public health emergency has continued, and it always seems like it's a little bit grayish around the time where things are renewed or continued. So our Swingbed consultant, Kerry Dunning, that has been working with us now for a couple of years, is just kind of go through the waivers and just reassure people what's in place, what to potentially take care of, and her general guidance that, you know, she's hearing out there in the federal world, and et cetera. So, but before we get started today, you know, I want to make sure and thank Joyce Fillenworth and David Conrad at the State Office of Rural Health for all of their support and being able to provide funding. For our contract, this is actually our last education webinar for our current contract. We will be moving into a new contract series in September, but we will be continuing with our monthly Swingbed education webinars, and hopefully at some point in time we cannot maybe be quite as focused on waivers and PHE, but it certainly sounds like it's going to be here for a few months to come yet. So I do also want to share that we did have 17 Swingbed dedicated individuals across the state that did complete the Swingbed Management Certificate Program that actually Kerry provided on behalf of Hometown Health. So really excited to be able to do that. That is also another program that later in the year we're going to be able to open back up once all of the contracting and everything is in place. So please be watching for those types of announcements here in a couple of months if you're interested in obtaining a certificate in Swingbed management. I think it's amazing that we were able to have 17 individuals complete the program given the type of year that we had and all of the different added on top of everything that you're already doing, roles and responsibilities and caseloads that each of the hospitals have. So congratulations to those individuals that did complete the program. The presentation for today and some additional handouts were distributed this morning. If you haven't received those, why please let me know and I will get those out to you. We will be recording today's session. I will be sending out the recording link to all of our Swingbed contacts, but certainly feel free to share and forward the recording link and the materials to any other individuals there at the hospital. So Kerry, I will go ahead and turn it over to you.
I appreciate it. Good day, everybody. I'll do a 2-second thing on COVID in the country because I have clients in 43 states right now, I think. And I was talking to Utah, Nevada yesterday, and they have a variant E. E is in Edward, but E that I hadn't even heard of. In Florida, we already have Lambda, and now we have the Columbia, as in South America, Columbia variant. So I think one of the things we're going to be looking at regionally first, but then we need to pay attention to nationally as these variants show up in different parts of the country. They don't tend to stay in that part of the country. They mosey on into the next state and the next state. So just keep your heads up while we're all having to learn new variants and get through all of this. So I'm going to talk about the waiver and go through a couple of things. The handouts that Becky just referred to are actually the documents that are in place to support this information at this point. A lot of this comes verbally from CMS during calls, during other presentations. Somebody will ask a question and they'll answer something and all of us madly write it down because we've been waiting for that answer. And while I'm saying that, I have queried CMS about 6 or 7 times and not gotten responses in 2.5 or 3 months now. And one of them is on cardiac rehab, which is a question that specifically came from your neck of the woods, meaning the state of Indiana, people asking about it. So it is not forgotten. I think CMS is just sort of inundated like the rest of us. So under the waiver, as you know, it's a Public Health Service Act, and that is a PHE or public health emergency that was put in place for this particular emergency on January 31st of 2020. That allows all of us, starting with the federal government on down to us actually in each of our programs, to support Medicare beneficiaries. All of this has to do with the health emergency, what the feds can control, and that is the PHE. And as you know, each of the insurance companies has done a little different version, but pretty much sticking to the fact that this is a major event. And if you don't know, you can go out and look up public health emergencies. They are public health emergencies every day, and some of them are caused by natural causes. In other words, there's a flood area, and then the flood area adds to people needing to be covered by health care and so forth. It has been renewed now. It's required to be renewed every 90 days. So you can see the dates, and the last one was July 19th, so we are covered into October of this year. Everyone, including verbally, the federal guys have said that they expect this to go through the end of the year. I don't know that was such a secure statement in May and June, but I think it is a much more secure statement now as states are again seeing these numbers rise substantially with the new variants. I do want you to know that CMS has said and has written that if they are going to end this PHE, they must give 60 days notice. That means we're not going to wake up on a Monday morning and find out they ended it Friday at 5. We will have 60 days notice to get back into whatever the routine might be at that point. And I think I have it on a slide, but if I don't, one of the other things that's sort of interesting is there is now legislation going through Congress to keep the 3-day waivers a permanent part of skilled services. So, and it's co-sponsored by 2 Democrats and 2 Republicans. And I think at this point in my life, I just want to copy the bill that says everybody got along on one thing in Congress this year. So there are some changes that will come out of all these waivers, but we'll know that once we can take a deep breath and look forward. There are a couple other examples I wanted to show you. This is not something that just showed up because of COVID. And if you don't know American history, and I was raised in New England, so the whole year of history started with the Revolutionary War, and on May 1st we might start studying any history past that point. But George Washington actually ordered inoculations against smallpox for all the troops. And considered it, which is why I have the thing about the military health emergency on here, considered it an opportunity for an enemy to purposefully spread smallpox. It was accidentally coming into the U.S. because Germans and French soldiers were coming to the U.S. to fight with the American forces against the English, and they had smallpox and had brought it into the country. So he ordered the inoculation. So the emergency for military, which I think our military, I don't remember the date, but they're now mandating inoculations for everyone in the service. It is for health, but it is also because if we start losing a huge number of soldiers to any illness, we would be at risk from other countries. So that's one thing to look at it. The other one is that the last time we really used PHE was in 2009. It was for swine flu. And that just allowed stockpiling, in this case, of Tamiflu to go near the states where they had the highest priorities at that point. I have said this for a number of years, but you need to know that we've had an epidemic or pandemic in the United States every single year since 2000. We are in a epidemic/pandemic era in our healthcare. So I think we're in this for the long haul. Hopefully not to this extent. I'm going to hope this is one of those 100-year events, but we'll see as we go forward. All right, so the manuals and things that you were provided, in case you want to read through any of the extra stuff, there is an ACO manual out there that I provided in case you are taking Medicare Advantage patients. Insurance companies will do their own things. I have included a fact sheet on the updated 3-day ruling. But then there are kind of two things initially that are going through that I want to make sure we're clear on. One is very clearly the federal government has said from almost the beginning, honestly, that just because somebody has COVID does not mean that's an automatic admission into a skilled bed or into any setting, but into a skilled bed on the topic that we're talking about. Just the presence of the symptoms, the presence of that of COVID is not what covers somebody, particularly in skilled care. It's not the diagnosis. It's the required services that we get reimbursed on in a skilled setting, and therefore are clinically charged with showing proof that they needed to be in a skilled setting. So in the case with most of the COVID patients, it will be a respiratory patient. They may need help from things simpler in vents, but we certainly have a number of vent patients in skilled setting these days. So just make sure when you are documenting and when your team is admitting people that COVID is a cofactor, but the diagnosis itself cannot get you payment from Medicare. The other thing is that you need to know, as there are surges available, we need to make sure that we are paying attention to the areas that have been, quote, affected by an emergency. This is going back into the language of the waiver that we are using now, because it says that we can have patients coming in that are not COVID positive, but they have been dislocated from other areas because of the emergency. So the words I have there in red, straight from one of the manuals you have, is neither the beneficiary, the hospital, nor the SNF need to be located in a particular area or experiencing COVID-19 surges in order for a beneficiary to take advantage of this waiver. That's the wording, and as Becky said when she started, I have it in red, but it really should be in gray, because there is no definition behind that, but that's where we have been allowed as needed to take patients in during this time period using the waiver. I'm going to strongly suggest, I think we've talked about it all along, that if you take a patient in because of the waiver, there should be very, very good documentation on why you needed to accept that patient, what was going on with the patient, what was going on in your area, et cetera. And that just is a defense mode as they start auditing and reviewing all this information going forward. And as I said, yes.
I was going to say, it looks like Crystal Halpin has shared a link in the chat. Let me open up chat a little more for me here. It says, the link states, an Office of the Inspector General report found that Medicare improperly paid for skilled nursing facility services when patients didn't meet our 3-day inpatient hospital stay requirement. Review the skilled nursing facility 3-day rule billing PDF fact sheet to help you bill correctly. Does the billing simply need to include the DR code? And it says our billing.
There is.
Go ahead.
Yeah, there is a DR code and there's an occurrence code that goes with it. So it's those two codes have to be on the claim. And if they aren't on the claim and they were paid, that's probably what the OIG is talking about. The OIG is going to be involved in this, and not only just for skilled, it's going to be in every piece of how Medicare paid for services once we get out of this. But yeah, the DR code, occurrence code also, those two codes have to be used. I think that's in one of the fact sheets that I sent, Becky. I'll have to read it afterwards, but I sent everything that was in writing.
Yes.
So that would be that. And then again, remembering that COVID does not have to be the primary code. It's like the best example is if somebody has a stroke, we're not going to put the stroke as a primary code. We're going to put the related issues that require the skilled stay, so that may be, they need for therapy. It may be need for additional meds. There may be other things that are qualifying somebody into skilled. So, yeah. And I would say thank you for who did that. And that's the one thing, is the more items that we find in writing that you can pass on to Becky and she can spread among you, the better off we'll all be, because this is, I think even that sentence in red right there isn't as clear as Medicare thinks it is, because they talk about it, but they loosen the statement when they're talking about it. So,
well, I do want to go on to share with you that she said that their billing department is concerned that if they don't document the beneficiary is directly affected by the pandemic, that the claim will be denied.
Well, that's not what CMS is saying, and that's why I've included not only the waiver statement in the material, so I would give the material where this is stated to your billing department, and I'm going to say very clearly, each facility has to make up their own mind on the risk they're willing to assume with this. Medicare is basically saying you don't have to have any COVID in your area, and they have said that verbally. But when we get back into how much money was paid out in this point, and OIG or other groups, that may be something we have to defend. So at a base level, we need to have documentation in our chart on why we accepted patients, particularly if it has something to do with the waiver. And then secondarily, I think internally, each of you and each of your hospitals have to come up with whatever your approach is going to be. And I don't think there's a right way or wrong way to do this now. I just think, and billing and coding are the two areas that are terrified, and rightfully so, of audits, because they literally have to go by the written rule. So I would defer to what your team decides to do. Does that make sense, Becky?
Yes, I believe so. Yeah. And really thank Crystal for pointing this out and facilitating this discussion.
Yeah, if you could send that to me afterwards, Becky, I'll send it out to a couple other people and see if they've seen it or they're hearing any other translation on it and get it back to you if there's a different one.
Will do.
All right, this is the act that's going through Congress. I don't know how fast, but it's going through Congress. Again, Democrats and Republicans saying that they're wanting to remove the 3-day stay. It's not in place. It's not passed. And even when it's passed, as you know, Congress passes it and CMS still has to put it in place. So we're probably a year or so away from that at best. So when we're looking at audits, since Crystal brought it up, I just was pressing. I knew Crystal was going to put that, right in the chat pane. The question really comes down to, did you earn the dollars? And what does that mean? And that's documentation, documentation, documentation. So I would take a chart of a COVID patient. I'd take a chart where there was a 3-day waiver that was used for COVID or not for COVID, whatever the case might be, and go through it and make sure the documentation shows the need for skilled strongly, and then why the decision was to accept this patient. You also need to look at your policies. If they're going to be audits, and I suspect they're going to be audits, they usually start with policies. And do we have our policies that we've been talking about, which are things like the plan of care and the ombudsman statement and quality? But more so, do you have a policy during this pandemic? Do you have a policy for that waiver that's in place and how you plan to use it? So I would double check those sort of things. I would be looking at your plans of care. In other words, is the plan of care appropriate to that individual that it's in place for? Are there measurable objectives? Are we including the patient and or patient representative in those decisions and so forth? I do think it helps for you in any time, but certainly at this point, with a number of things, not just the 3-day waiver, that we are making sure all the policies are up to date. And I'm going to go with that back through one more thing, because I get questioned on this over and over and over. What's really interesting when you look at the care planning, and the things in red, I didn't put in red, that's the last version of changes made by CMS. And if they are to change this again, they would take the red off those and put the new words in red. But it's not just that we have to have an IDT. That's in one set of the regs. The IDT is also inside of the comprehensive care planning. As you know, we've got to have a baseline care plan in place within 48 hours. There is literature out there from CMS that says that they expect the first care plan meeting or the first IDT meeting, if you are combining them, to include that baseline care plan to be reviewed by the IDT, so that everyone has a chance to see what needs to be updated, and that baseline care plan is your working document, your working care plan until the timing is requiring you to do a comprehensive care plan. If we take medically or clinically complex patients, we are going to get into comprehensive care plans. If we have short stays because they're mostly ortho patients, we're less likely to get into comprehensive care plan. And that means that baseline care plan becomes more important as the working document. But this again repeats, and I can tell by the red, by looking at this now, this was last updated in 2018, because that's when they added the CNA and the dietary requirements to the team as necessary. You just need to make sure that your IDT includes the physician or extender. I was asked a question the other day. It was kind of interesting, which is why I kept saying physician as almost like a disregard to the extenders. And it made me stop and think, well, one, it says very clearly attending physician, and that has been in writing, as you can see from the beginning of the requirements in this particular piece of federal law. But I went back and read the whole regulation, and there is a statement in there that I will paraphrase right now, but it basically says the attending physician, if the attending physician is unable to attend the care plan meeting, and it says he can appoint his PA or NP. So it says if the physician can't attend. To me, that's, again, that's saying that the preference by regulation would be to have the physician in the room. We have gotten very used to, in our settings, using mostly NPs, and I haven't seen Medicare kind of lasso that back to only physicians. But if we're not having a physician, not having an extender in our team meetings, we're going to be in trouble going forward. So please make sure that you're working through that and all the difficulties that may imply going forward. So Becky, I think that's basically, I was going to say one other thing. I think there was a question on the spell of illness. Is that correct, Becky? That's come up a couple of times?
It had just come up a couple of times as a question.
Okay.
I think it's kind of the phrasing of that, and just wanted to make sure they were understanding the full term. Right.
So spell of illness in Medicare language, you notice I didn't say in the English language, I said in Medicare language. Spell of illness is day of admission to day of discharge. That's a spell of illness. So if somebody's discharged and comes back into your Swingbed program, so they were in your Swingbed program, have to go back to the hospital, and they come back in, that's a new spell of illness. The reason that's important is remember that we can, within 30 days of discharge from acute, admit somebody to a Swingbed program. So in that case, the spell of illness that we would be talking about would be the 3 or 4 or 5 days they were last in acute. The same thing when we're talking about readmitting somebody to a swing bed. They've gone home, they find out they can't take care of their father or their mother as well as they thought they could. They can readmit to your swing bed program within 30 days, as long as it's related to the spell of illness. And that spell of illness for you is actually what you treated for in the swing bed, but it's directly related to a required 3-day stay in most cases, but a required acute stay. Does that help?
Yes, I believe it does, and just provides a little additional clarification. Before the meeting today, I had another question come in, and I think this is something that will be of interest to most of our critical access hospitals too. It came from a case manager at one of our critical access hospitals, and they were reviewing the handouts for the Swingbed program today, and wondered if there are any waivers in place for ambulance transport home at the time of discharge when a patient is COVID positive. They've had a few cases where of patients with Medicare or Medicaid that cannot get away home due to being COVID positive has been an issue for them. The family doesn't drive, or they don't have anyone to come to get them and are unable to drive themselves. They are also ineligible for public transportation or medical transportation like a van due to being COVID positive. Are there any waivers in place or anything that you know of that would be helpful in these situations, or just any suggestions you have in general for patients in the future?
And that is a really good question. And only a case manager would understand the complexity of what was just said, because they work every day trying to get transport. There are some changes in the rules, not because of COVID, that are coming down the pike. Let me query an attorney, healthcare attorney that I work with, because I know she was talking about some changes they expected, but it wasn't because of COVID, but it was because there was an understanding that getting transportation for people is a real problem. You know, whether that's getting them back to a doctor's appointment or getting them home from one of our settings. So let me see if she thinks there's enough of that in place, or what she says, and I'll get an answer back to you. But as far as I know, there's no specific waiver. That's answer number one. But answer number two is, I know there's already discussions about transportation being a serious problem. So let me see if I can get with her. She's hard to catch up with. But actually, she's an attorney I really like, and I don't know if that's almost an oxymoronic statement sometimes, but I tell her to her face, she is the nicest, mean person I've ever been around. She has this sweet voice and is standing there telling you that a program you're working with has got a $3 million fine, but she says it in a sweet voice. So she's very good and very knowledgeable about healthcare. So that's the way I'll go with that, Becky, just to triple check to see if there are other options.
Yeah, I told them that I felt like if you didn't know, you would know who to turn to see if there was any alternative.
There's
to
no
this.
specific waiver. I can tell you that outright. They did not include that in the initial waivers, but there's this side conversation going on. Let me see if it's in place yet and what it means.
Yeah. I'll also share this question with Joyce Fillenworth at the State Office of Rural Health. I don't believe she was able to join today.
Okay.
And she's also tried to assist with different types of transportation issues and has been helpful in some instances on coming up with some alternatives. So I'll share it with her too, and see if, and share with the entire group any kind of positive feedback or any alternatives she might have as well. So appreciate that. So I want to.
I will. I was going to say real quick. I'm working on the grant cycle is changing here. So I have a new grant that's really how we can access more availability within our communities of assisting people. So it doesn't have to be healthcare directed. It can be churches and civic groups and so forth. But one of the questions that we've got on the list to try and figure out is how people are dealing with transportation. Because I know some places, for instance, in Iowa, they've cut a special taxi rate. Now, I don't know how that works during COVID. I'll have to ask. But everybody's coming up with different plans. So I think we're going to hear a lot more in this next year, because this is a multi-state grant of options people have creatively found. And I'll be glad to share that with your group.
Great, that'd be great. We have another question. Zach is asking, in our area, patients and families had preferred the swing beds to nursing homes, secondary to concerns related to COVID in nursing homes. Does this concern or fear qualify as a patient who is affected by COVID? a good question.
Yeah. Well, we have to write down, obviously, patient concerns. We still have to admit to our policies. I guess that's the best way. So they have to meet your criteria for your Programs Act. But I think that is a valid concern that we should have in our documentation. The question, I know we're facing it in Florida right now. If you weren't on the beginning, we're in a hotbed here. Is I suspect, I haven't looked at Jacksonville directly, I probably should, but nursing homes are going to be closing their doors again. They can't admit during this. We saw that, from the initial shock of the facility in Washington. Everybody else kind of rolled past that, where once it gets into long-term care, it spreads quickly. So they'll be closing their doors to new admissions, I suspect. In that case, that takes more validity as part of your a case management note as to why somebody, for instance, is not only in your Swingbed program, but they may have a longer length of stay than you traditionally do because it's going to take them longer to heal. So that would be part of that explanation. And if I know Zach very well, which I do, I'll get an email. I didn't answer it the right way. So.
We'll give him a minute to respond here in chat.
Because I just picked on him.
Yeah. Any other questions out there? We have just a minute or two left here. He did make a comment. I don't know if you can see chat, Kerry, but he was just curious, is the reasoning, just curious, is this reasoning would validate using a waiver? And he said, thanks for the response. So.
Yeah. Here's the really bottom line. And we said this before we had this brutal thing facing us. Documentation makes or breaks you. That's just the simple thing, particularly in critical access. As happy as you are that you do not have to complete an MDS, and I'm happy for you, the fact is the MDS is a barrier. The first thing when they walk into a skilled nursing facility or into the PPS Swingbed programs is they study the MDS. So they don't go immediately into a chart. And if they go into a chart, then they tend to go to one section to see if it supports what was on that one section of the MDS. The reason that I think you're more at risk is I have never seen the perfect chart. In fact, I've always said if I saw a perfect chart, somebody's lying. We have too many people, too many shifts, too many different things, too many professions involved in it to have a document that flows perfectly. So we have to go back and check our own documentation and make sure the main reasons that, and I'll say it this way, why Medicare or Blue Cross Blue Shield or United or anybody's paying for that patient, it has to be in our documentation. So that I think should be an audit routinely in your programs. Go back and see what it says. Does it make sense? Did it really say how sick this patient was? Or do we use check boxes on? And I'm not trying to be critical of nursing now. I think just EMRs have really kind of messed up with good documentation in many cases.
Any other questions? I encourage you to read through the handouts, the documents that were distributed earlier today. If you do have questions about any of the information included, let us know and we'll get back to you as quickly as possible. And Kerry, I'm not seeing any other questions or comments in chat, but really appreciate individuals jumping in today and asking some really good questions.
Yep.
So.
And I've got one to follow up with, and I'm just going to end this by saying to everybody, please stay safe.
Yes, absolutely. And thank you so much for all that you're doing out there in the critical access hospitals every day. So more to come, and be watching for announcements related to future certifications and future education programs. And if you have specific requests on information that you would like covered during our monthly meetings, we're always open to suggestions and always want to meet your needs. So thank you so much, everyone. We really appreciate your time.